Good morning. Thank you all for being here and welcome to the Subcommittee on Health's first hearing of the 116th Congress. First, I would like to thank all of you who were present in our suicide prevention hearing last night. I appreciate everyone's commitment to tackling the issue, and today's hearing is another important step in our efforts to end the epidemic of veteran suicide. I believe we had productive dialogue on the subject yesterday, and I look forward to our continued discussion today. In the 116th Congress, the Health Subcommittee's key focus is ensuring equitable access to high-quality health care for our nation's heroes. The Veterans Health Administration is the largest integrated healthcare system in our country, serving over 9 million enrolled veterans annually at over 170 medical centers nationwide. It is vital that we ensure VHA is meeting the healthcare needs of these deserving veterans. I'm also committed to ensuring rigorous oversight of the VA's implementation of community care under the Mission Act enacted in the 115th Congress. As VA rolls out this program, it is crucial that it is well implemented to ensure that veterans have access to the care they need while also preserving the unparalleled services that only the VA can provide. Chairman Takano has given our committee an important goal with his VA 2030 vision, and it will be the duty of this subcommittee to identify and carry out the objectives within our jurisdiction. I intend to make this subcommittee a bipartisan and collaborative body, and I encourage my colleagues on both sides of the aisle to share with me their thoughts and concerns. That brings me to the work before us. Today, we are holding the first Health Subcommittee legislative hearing of the 116th Congress. We will consider 8 pieces of legislation, including discussion on 3 important areas: suicide prevention and mental health, cannabis, and whole health programs. Each year, roughly 6,000 veterans commit suicide. Each and every one of these lives lost represents a heartbreaking tragedy. Many of these veterans were not enrolled in VA health care. We must ask how VA can better assist those currently enrolled and how it can better reach those not enrolled, and how can VA partner with different government agencies and community partners to expand its public health approach model for suicide prevention. As we discussed last night, the tragedy of veteran suicide is not just a VA problem, but rather a topic that needs to be addressed through partnerships across agencies and community resources to provide the best possible services to our veterans. To that end, we will be discussing 4 bills today to enhance VA suicide prevention and mental health programming. In addition to these 4 bills, we will discuss 3 proposed bills on cannabis. 33 states, to include my home state of California, have now legalized medicinal cannabis. The bills being discussed today will help VA, a national leader in health research, conduct research on healthcare benefits of cannabis for veterans, and ensure healthcare providers and veterans can have informed conversations about the use of cannabis while abiding by state-level cannabis programs so that veterans in these 33 states have access to the same health care treatment that their civilian counterparts have access to. Last, but surely not least, the final bill for discussion today will be centered around VA's whole health program. In May 2018, VA designated 18 whole health flagship sites and 13 additional whole health design sites, which promote a whole veteran approach to health and center around what the veteran finds important to his or her. The whole health bill, introduced by Vice Chairman Lamb, will ask the VA to generate a report to Congress on the implementation, utilization, and efficacy of VA's whole health program. As chair of this health subcommittee, I'm truly proud of the work we are doing here today, and I'm especially proud of the way we are doing it in a bipartisan manner. In closing, I would like to thank our witnesses for appearing, and I look forward to your testimony. With that, I'd like to recognize Mr. Mercer, who is standing in for Ranking Member Dunn, who I understand will be arriving here shortly, for any opening remarks he may wish to make. You are recognized.
Thank you, Chairwoman Brownlee, very much. Yes, Ranking Member Dr. Dunn is on his way. It is a pleasure to be here with you at our very first Subcommittee on Health hearing of the 116th Congress. I hope that we will have a productive 2 years and that our work will continue to represent the spirit of patriotism and bipartisanship that veterans embody. On that note, we do want to note that we do have disappointment that the agenda for today's legislative hearing was developed without any input from the minority. There are a number of worthy proposals from our colleagues on both sides of the aisle that Ranking Member Rowe and I would like to see considered this morning. However, our request to include them in today's hearing were, in fact, denied. One of them is Dr. Rowe's bill, H.R. 1647, that would expand eligibility to Department of Veterans Affairs vet centers to members of the National Guard, Coast Guard, and Reserve. As was discussed in detail at last night's full committee hearing, approximately 20 service members and veterans die by suicide every day. Approximately 4 of those suicide deaths occur among members of the National Guard or Reserve who never deployed and are not eligible for VA care. Ensuring that those individuals are able to access readjustment counseling services could literally be life-saving. Given that, and that 4 of the 8 bills we will be discussing this morning are similarly aimed at preventing suicide among our military and veteran populations, a priority we all share, it is a shame that Dr. Rowe's proposal is not also up for discussion today. I certainly hope that this was a one-time oversight and that we can return to a more collaborative working relationship moving forward. That said, I am grateful to all of our witnesses for being here this morning, and we look forward to receiving input on the proposals before us. With that, I yield back.
Thank you, Mr. Mercer, and I just will add that we have several Republican bills before us today, and Dr. Rowe's bill or any other bills for that matter doesn't mean that they've been rejected. We're just not hearing them today. So I appreciate your comments. And we have 2 great panels joining us today. And I thank each of you for joining us in what we hope to be a fruitful discussion on these 8 bills. For the first panel, we have Representative Blumenauer from Oregon. Next, we have Representative Bredensi from New York. Next, we have Representative Correa from California. Next, we have Representative Lamb from Pennsylvania, Representative Rose from New York, and last but surely not least, we have Representative Stubbe from Florida. With that, I now recognize Representative Blumenauer for 5 minutes.
Thank you very much, Madam Chair, and it's a pleasure to be here. I wanted to focus in on particularly as it relates to the issue of cannabis and our veterans. You've rightly identified a truly tragedy in terms of what's happened to our veterans in terms of suicide, pain management, a series of things. We're convinced that there's an opportunity in the area of medical cannabis to make a difference. I'm pleased that in the past we've been able to move things along, advancing, demonstrating majority support on that. This is the first time we've had a hearing like this with a substantive committee, the authorizing committee, not just appropriations. One of the great tragedies of our time is the failure to adequately address the needs of veterans returning home from Iraq and Afghanistan. We sent more than 2 million brave men and women to fight under very difficult circumstances, to say the very least. And while there continue to be debate about the wisdom of entering these wars, we can all agree on the need to provide the care to those veterans as they return home with wounds that are both visible and in some cases unseen. And it's no secret that our VA facilities have struggled to absorb these returning veterans, which coincided with a national opioid epidemic. And of course, it's not just veterans. Opioids steal the lives of 115 Americans every day. More than 30,000 were killed last year. As veterans with PTSD, chronic pain, and any number of ailments are looking for relief, lethal opioid overdoses among VA patients are almost twice the national average. We're doing something wrong. This is a time when an overwhelming number of veterans tell me that cannabis has reduced PTSD symptoms, their dependency on addictive opioids. We've seen evidence that medical cannabis can be a less addictive way to manage pain and other symptoms currently treated with opioids. The National Academy of Science and Medicine recently confirmed the efficacy of medical cannabis for chronic pain in adults. Another study in the journal Pain found no evidence of serious side effects among medical cannabis users after a year of treatment. A study published in JAMA, the Internal Medicine, found states with medical cannabis saw 24% reduction in opioid overdose deaths. Currently, 47 states, the District of Columbia, and most territories have passed some laws that provide for legal access to medical cannabis in some form. Well over 1 million patients across the country, including many veterans, now use cannabis on the recommendation of their physicians to treat conditions ranging from seizures, glaucoma, anxiety, chronic pain, nausea, and PTSD. Yet the VA official policy prevents the doctors who know the veterans best from recommending medical cannabis to our veterans, even in states where it's legal. As a result, veterans are forced outside the VA system to seek a simple recommendation for treatment for these conditions or any eligible conditions granted to them by state law, or even consult with them about it. The Veterans Equal Access Act that I've introduced would reverse this policy and allow VA healthcare providers to provide recommendations and opinions regarding treatment that is legal in the veteran in a state where medical cannabis program is authorized. Veterans should not be forced outside the VA system to seek a treatment that is legal in their state. VA physicians should not be denied the ability to offer recommendations they think may meet the needs of their patients. And I hope my colleagues will join me in supporting this effort. It's no secret I've been working on this issue for a number of years. I have talked literally to thousands of people about medical cannabis, including veterans who tell me some of the most heartwarming stories. I appreciate the subcommittee's attention to this. This is something that is overwhelmingly supported by the American public. Survey research suggests in the range of 90%. In your home state of California, you had a very visible example at the polls. In Florida, it was over 70% that approved it. It's time for the federal government and the VA to keep pace with what the American public wants and an opportunity to make the lives of our veterans better. Thank you very much.
Thank you, Mr. Blumenauer, and this is an important bill. Thank you for bringing it forward, and as you said, as you hear from your veterans, I hear from mine as well, so thank you very, very much for your bill. I don't see Mr. Brindisi, so we will move to Representative Correa from California. Mr. Correa.
Thank you, Madam Chair and Ranking Member Dr. Dunn. It's good to see both of you. I want to start out by thanking our veterans for your service to our country and for your sacrifice, not only of you and your families. Thank you again, Ms. Brownlee and Mr. Dunn, for your invitation to appear before you today. Appreciate the opportunity to testify about this bipartisan legislation written by myself and Mr. Higgins, H.R. 712, the VA Medical Cannabis Research Act. As you know, veterans experience physical and psychological injuries at a higher rate than their civilian counterparts as a result of their military service to our country. Unfortunately, the current treatment of prescription opioids to address PTSD and chronic pain has at times been ineffective and has had dangerous results such as addiction or even death. In response to this crisis, Congress correctly and the VA have joined other national organizations trying to figure out how to reduce veterans' addiction of opioids. 20 veterans a day commit suicide. We've got to find better ways of addressing the needs of our veterans. Solution, over the years, when I was in California, sitting on the Veterans Affairs Committee, chairing Veterans Affairs, I used to get a stream of veterans coming to me and quietly and privately asking, can we use cannabis? Can the VA prescribe cannabis for us? Can we talk to our doctor at the VA about cannabis without losing our VA benefits? And of course, the answer is yes, you can talk to your cannabis about cannabis with your doctor at the VA, but the problem is there's nobody at the VA that can give you information about how cannabis can benefit you. Time went on. We recently had 2 polls, one by the Afghanistan Veterans of America. 80% of those veterans support cannabis research, support looking into cannabis for veterans. The American Legion did another poll. 92% of those veterans support research into cannabis treatment of veterans and their invisible wounds. Solution? This bill. This bill requires the VA to conduct double-digit blind clinical test trials on the impact of different forms of cannabis and delivery methods of cannabis on specific health conditions of eligible veterans of PTSD and chronic pain. Madam Chair, members of this committee, a few years ago, after the veterans came to me in my district and said, Lou, we want you to talk to us about cannabis, started visiting different cannabis groups in my district. One of them was a cannabis shop, legal medical cannabis shop in my district. Went and I asked the lady at the counter, I said, tell me what it is that you do to talk to folks that come to you to ask for medical cannabis. How do you prescribe different cannabis strains for them? She started telling me what you did, and I said, ma'am, what are your qualifications? What is it that got you qualified to talk to patients about cannabis? And she said, I've been using cannabis for 20 years. Those were her qualifications. And I say to all of you here, it's time to move on. It's time to do research. It's time to make sure that our veterans get to know what cannabis is good for and what cannabis is not good for. We need medical research. And that's why I brought this legislation forth, to simply tell our veterans what cannabis is good for. We owe our veterans a tremendous amount. The least we can do is make sure we're giving them the proper treatment for those invisible wounds that they brought back from the battlefield. Thank you very much.
Thank you, Mr. Correa, and we miss you on the committee, but very happy that you are continuing to persevere, and one of your priorities that I know has been a priority for you, and so thank you for continuing on, and I agree we need to push the VA forward on this issue.
Madam Chairperson, I miss being on this committee. I think it's that one place in Congress that both Democrats and Republicans come together to do what's right for all veterans.
Thank you very much. I now recognize Mr. Lamb for 5 minutes.
Thank you, Madam Chairwoman. And before I get to my bill, I just want to thank Representative Blumenauer and Representative Correa for their efforts and for really leading the way on this issue. You know, we say all the time that veterans deserve the best when it comes to health care and medical treatment, and I think part of what that means is that we have to look at the VA as an institution that can lead, that can break new grounds, that can cross these frontiers, and when there's innovation and reform in health care, we need to be at the front, not behind, not entrenched in the old way of doing things. And I think these are some great efforts to try to help us move forward on an issue that can get veterans better treatment, that can attract a better workforce that actually wants to be able to prescribe these treatments that they know work. And so I thank you for your efforts. The whole health bill that I'm introducing is really in the same vein. In a lot of areas of American healthcare right now, we're seeing experimentation with a wider array of traditional and non-traditional treatments, anything from incorporating chiropractic services, massage, acupuncture, to just whole health coaching in diet and nutrition and sleep, acupuncture, meditation, yoga, I mean, Tai Chi. There's all these things out there, and different practices work for different people. So the idea of this bill is that we would like the VA to look at the places where their whole health program is in effect right now, tell us how it's doing, but more importantly, tell us what the availability and access is across the VA system for veterans and where there is no access and availability, and help us figure out how we can expand it. I had the opportunity last year to visit the whole health program at Washington, D.C., which is one of, I believe, about 18 or so places that they have the whole health program in place. And what you saw there were patients who were happy and successful and felt like they had some measure of control over their own health care. And that's the biggest thing. We talk about the practices themselves, the way that yoga can help someone who's dealing with chronic pain. That's good, but what struck me as even better is that we were giving veterans an array of options and the ability to try a few different ones and see what works. And when I remember asking an older Vietnam veteran that was there, do you like this program? Yes, of course I do. Why do you like it? And he was like, because I get to pick. I get to pick which classes I come to and how often, and it doesn't cost me anything. And if I like one of the instructors and I like the other people who come to the class, I can keep coming back, and they get to know each other. And there's plenty of research that shows why that's a better way to do healthcare. When someone feels like they have control over it, it's just going to work better. But I think we all know that is common sense. So that's what's behind this bill, the whole Veteran Act, introduced by myself and my colleague, Mr. Ryan from Ohio. So I appreciate everybody's support that can get behind it, and I think we can do some great things to help veterans and push the frontier of how we're doing healthcare going forward. Thank you, Madam Chairwoman. I yield back.
Thank you, Mr. Lamb, and again, thank you for bringing this important bill forward. And I now recognize Mr. Rose for 5 minutes.
Thank you, Madam Chairwoman, and thank you, Ranking Member Dunn. And just to reiterate my friend Connor's statements, I know Representative Blumenauer left, but Rep. Correa, thank you for your leadership on this issue as well. As a more recent vet and someone who still serves in the Guard, we need to utilize all tools available to us to deal with folks as they're still encountering the wounds of combat and of service. So thank you again. Like many veterans, as I am, the issue under discussion, that of veteran suicide, is personal. Based on recent events, it's clear that this mental health crisis requires action, both on the part of members of Congress and certainly on the part of the VA. The rising rate of veteran suicide is beyond a tragedy. Every veteran who struggles with mental health issues, physical scars of war, and who dies by suicide is another casualty of combat. And they're a casualty of combat and of war and of their service, irrespective of whether they deployed to war or not. And we're noticing a truly jarring phenomenon: veterans attempting or completing suicide on VA campuses. 4 veterans just this month alone lost their lives to suicide within a VA facility or on VA grounds. Something must be done about this, and we need to do it now. A thorough, multifaceted approach is required to not only assess whether the services these veterans received were adequate, but to make sure that the VA has the framework to provide the necessary data to Congress and to other appropriate entities. That's why my legislation, I'm proposing the Fostering Intergovernmental Health Transparency in Veteran Suicides Act, or Fight Veteran Suicides Act, is a key first step. This bill would make sure the VA reports critical information to Congress when these events occur and requires these metrics quickly. Having these data points would help Congress fully understand the scope of this crisis. As I've said time and time again, we need all the information necessary so we can better serve our fellow veterans in need while ensuring the VA has the necessary tools and resources to tackle this trend properly. I'd like to thank AMVETS, Paralyzed Veterans of America, the Reserve Officers Association, the Military Order of the Purple Heart, as well as the Disabled American Veterans here with us today for their support of this bipartisan legislation. And I strongly urge my colleagues to support it as well. Thank you for addressing this, and I yield back the balance of my time, Madam Chairwoman.
Thank you, Mr. Rose, and thank you also for bringing this bill forward. I think the suicides that we have all witnessed on VA campuses, in my mind, is a cry for help. And I think that's what last night was about, and I think your bill, in terms of reporting, is extraordinarily important. So thank you for bringing it forward. And I will say thank you to the first panel, and we will have a little transition period here where we set up the second panel, and when that happens, I will introduce the second panel. Thank you very much. I now recognize the second panel, and we have Dr. Keita Franklin, National Director of Suicide Prevention from the Department of Veteran Affairs. Dr. Franklin is accompanied by Dr. Tracy Gaudet, Director of Patient-Centered Care, and Dr. Larry Mole, Chief Consultant of Population Health. Next, we have Joy Elam, National Legislative Director of Disabled American Veterans. And also here is Carlos Fuentes, National Legislative Director at Veterans of Foreign Wars. Last but not least, we have Jeremy Butler, Chief Executive Officer at Iraq and Afghanistan Veterans of America. Whoops, wrong person. I'm sorry. We have Stephanie Mullen. I apologize. It's a good reason to look up as opposed to, we have Stephanie Mullen, Chief from the Iraq and Afghanistan Veterans of America. With that, I now recognize Dr. Keita Franklin for 5 minutes. Dr. Franklin.
Good morning, Chairwoman Brownlee, Ranking Member Dunn, and members of the subcommittee. Thank you for inviting us here today to discuss a number of important bills about mental health and suicide prevention, as well as VA policy on veteran participation in state-approved marijuana programs and cannabis research and whole health. Madam Chair, before turning to the specific bills, I want to emphasize that suicide prevention is a top priority in the department. I think you heard that last night. Suicide is complex. It's a serious national public health issue that affects people from all walks of life, not just veterans, and for a variety of reasons. And while there is much to learn, we know that it's preventable, we know that treatment works, and that there is hope. And I want to thank you for your leadership on this issue. Although VA is creating the path forward, we know that one agency alone cannot solve the issue. Preventing suicide requires bundled approaches working across multiple sectors, and our work is guided by the National Strategy for Preventing Veteran Suicide. This strategy, published in 2018, expands beyond crisis intervention and provides a framework for identifying the priorities, organizing efforts, and focusing resources through a broad public health approach with an emphasis on comprehensive community-level engagement. It's a plan for what we can all do to work together to prevent veteran suicide across the entire nation, not just within the four walls of the VA. Legislators play an important role in this integrated approach, not only because of the importance of policy interventions, but also in your ability to reach out across the nation. For example, as you may know, this month we started working with you and other members of Congress to spread awareness about this important topic through a PSA drive on Capitol Hill. Again, we want to thank all of you that have already developed your PSAs and for your continued support and concern for this important issue, veteran suicide. So just turning right to the bills that are presented today. These are complex issues. They call for multi-layered solutions that require a rigorous level of review and analysis. And we provided some of our views in our written statements, and we're prepared to continue that conversation today. And I'll jump right in with the Veteran Over-Medication and Suicide Prevention Act of 2019. This bill calls for the VA to partner with the national academies and to conduct in-depth post-mortem data analysis. Data and surveillance are at the core of our comprehensive public health approach, and they inform our suicide prevention efforts, and our partnerships with agencies like the National Academy are an essential piece to what we do. We appreciate Congress's interest in advancing those partnerships and in furthering how suicide data is collected, analyzed, and reported. VA was one of the first institutions to implement a comprehensive suicide surveillance and has continuously improved data and surveillance related to veteran suicide. Part of this bill reflects a specific requirement to further that analysis that we already do. Other pieces in the bill involve outside organizations and authorities that we don't directly own, and therefore it will make full compliance with the proposed bill in its existing form very difficult to implement. Yet we know there's room to improve, and this is why we're eager to work with the national academies and to further study this issue, and I do stand ready to work through any and all details and barriers with this committee. Moving to the next piece of legislation related to the draft suicide notification bill. This would require VA to submit notification of veteran suicide deaths or suicide attempts that occur on VA facilities to Congress within 7 days of the event. VA supports this legislation. There are a few details that need to be worked out in terms of technical issues, ensuring that we preserve surviving family members' privacy and dignity with regard to deaths that occur, but regardless, we're pleased to work with the subcommittee on this initiative. The two remaining suicide-related bills call for GAO review of suicide prevention MOAs and our memorandums of agreement and understanding, and a review of the role of our suicide prevention coordinators. VA would defer to the GAO on these bills. We defer to the GAO on these proposed bills. I would let the committee know that we are already in the midst of an in-depth analysis on both of these issues, and I'm happy to turn over and share any of that information with this committee. Third, I'm moving from the suicide prevention bills to the piece on cannabis. The VA Medical Cannabis Research Act of 2019 would require VA to conduct a clinical trial to examine a multitude of health outcomes among veterans with varying medical diagnoses, and would involve multiple strains of cannabis compositions and routes of administration. Typically, a smaller early-phase trial designs would be used to advance our knowledge of benefits and risks regarding cannabis before moving to a type of more expansive approach as described in this proposed legislation. VA is currently supporting a clinical trial of cannabis for the treatment of post-traumatic stress disorder. Any trial with human subjects must include an evaluation of the risks and the safety and include the smallest number of participants to avoid putting subjects at increased risk unnecessarily so. And for these reasons, we don't support this proposed legislation. I do have Dr. Larry Moll here to talk to you more about that during the remaining of the hearing. And then moving to the Veteran Equal Access Act and the Veteran Cannabis Use for Safe Healing Act. This would authorize physicians and other healthcare providers in VA to provide recommendations, opinions, and for H.R. 1647, the completion of forms regarding participation in state marijuana programs. VHA's current policy prohibits VA providers from recommending and making referrals to or completing paperwork for veteran participation in state marijuana programs. This prohibition is a result of the Drug Enforcement Agency for guidance that's pushed out from that agency, which advised VA that no provision of the Controlled Substance Act would be exempt from criminal sanctions as a VA physician who acts with intent to provide a patient with means to obtain marijuana. In addition, this proposal would authorize VA providers to discuss marijuana use with their patients, record that use in the patient's medical record, and prevent VA from denying a veteran any benefit for participating in a state-approved marijuana program. Please know that our existing policy in VHA already permits discussion and documentation and clearly states that veterans will not be denied benefits by discussing this information with a VHA provider. Thus, VA does not support this bill. The draft VA Whole Health Bill would require VA to submit to Congress a report on the implementation of VA's February 1st, 2019 memorandum on the subject of advancing whole health transformation across VHA. Specifically, this report would include an analysis of the deployment of whole health services at 36 facilities. VA supports this draft bill, but notes that Congress may wish to consider extending the draft bill's requirement to a VHA-wide enterprise update. In addition, a thorough research report on veteran outcomes, cost, utilization, workforce engagement, burnout, and implementation will be provided to Congress on the 18 facilities currently deploying all aspects of whole health in March 2021 as required by the CARA legislation. Madam Chairwoman, in conclusion, I cannot emphasize enough the commitment of the Secretary and all of the VA to use every effort to prevent veteran suicide and continue to equip and empower all veterans with the resources and care that they need to thrive. We appreciate the committee's attention to this issue. We pledge to work hand in hand with the Congress on innovative and evidence-based approaches to this problem. This concludes my statement, and I'm happy to answer any questions. Myself, my colleagues are here to answer any questions that any member of the committee may have.
Thank you, Dr. Franklin, and I now recognize Joy Elam for 5 minutes.
Chairman Brownlee, thank you for inviting, and members of the subcommittee, thank you for inviting DV to testify at this legislative hearing. We are pleased to offer our views today on the bills under consideration by the subcommittee. In accordance with DAV Resolution Number 023, we are pleased to support H.R. 712, the VA Medicinal Cannabis Research Act of 2019. This bill would direct the VA to perform clinical research to determine whether cannabis is able to reduce symptoms associated with chronic pain and how it may affect alcohol use or dosage of certain medications for veterans with PTSD. We concur that research is necessary to help clinicians better understand the safety and efficacy of cannabis use for specific conditions that often co-occur in the veteran population, such as chronic pain and post-traumatic stress. DAV also supports the draft measure being considered that requires GAO to conduct an assessment of the role of VA suicide prevention coordinators and their responsibilities within the VA healthcare system. The study would assess associated workload, vacancy rates, adequacy and appropriateness of training and oversight of these positions, and how these factors may vary across the system. VHA guidance for delivery of mental health services allows for local variation in programs, and thus training and oversight of the suicide prevention coordinator position could differ somewhat from site to site. Because of these ambiguities and the importance of the coordinator's responsibilities, DAV agrees this study could yield important information, and thus we support the draft bill. The draft measure focused on advancing VA's whole health transformation model would require the VA to report on access and availability on each of several complementary and integrative medicine practices. In accordance with DAV Resolution 277, we support veterans' access to a full continuum of care, including alternative and complementary care such as yoga, massage, acupuncture, chiropractic care, and other non-traditional therapies. DAV is aware that some facilities may not offer a full complement of these types of services or may have to limit the number of visits for massage therapy or other popular integrative treatments. The report would help to determine to what extent these services are available across the system for veterans that prefer them over more traditional types of care. To provide a more complete picture, DAV recommends and suggests that the study also include complementary and alternative services VA provides through its Veterans Community Care Program. We need to ensure these, missed a page. DAV supports the draft bill that would require GAO to report on the effectiveness of VA memoranda of agreement and memorandum of understanding with non-VA providers to carry out suicide prevention activities and mental health case management services. We need to ensure these agreements hold community partners accountable for delivering evidence-based, high-quality mental health services to veterans who need them. Therefore, community partners or network providers should be held to the same competency, training, and quality standards that VA mental health providers are required to meet. The draft bill would provide needed oversight of agreements with non-department entities, providing mental health services to veterans to determine regional variances and the extent to which VA tracks health outcomes of such entities. H.R. 100, the Veterans Over-Medication and Suicide Prevention Act of 2019, calls for a study aimed at identifying suicides among veterans that may be attributed to over-medicating patients or inappropriate prescribing patterns in the VA. DAV supports the intent of the bill and certainly agrees that research and proper oversight of VA clinical practices are necessary, but it is difficult to assess if appropriate treatment protocols were followed without looking at individual case studies, especially in cases of medically complex patients with co-occurring physical and mental health conditions. For these reasons, we urge the subcommittee to consider working with VA subject matter experts to revise certain provisions in the bill related to data collection so that it can better advance the important goals of improving patient safety, improve polypharmacy management, and reducing suicides among veteran patients. Finally, DAV has no objection to favorable consideration of the draft measure requiring VA to notify Congress about any suicide or attempted suicide of a veteran that occurs on the grounds or in a VA facility. Madam Chairwoman, this concludes my testimony. I'd be pleased to respond to any questions from you or other members of the committee. Thank you.
Thank you, Ms. Elam, and I now recognize Mr. Fuentes for 5 minutes.
Chairwoman Brownlee, Ranking Member Dunn, and members of the subcommittee, thank you for allowing the VFW to represent our views on legislation pending for the committee. The VFW is proud to support the VA Medicinal Cannabis Research Act 2019. VA's over-reliance on opioids to treat chronic pain and other conditions has unfortunately led to addiction and even death, such as Jason Subcommittee, who died from an overdose of the medications he was prescribed by his doctors at the Toma VA Medical Center. The VFW is proud to have stood next to Jason's family and many members of the subcommittee to champion the Jason Subcommittee Memorial and Promise Act, which required VA reduce the use of high-dose opioids. To its credit, VA has made concerted efforts to ensure it properly uses pharmaceutical treatments under the Opioid Safety Initiative. VA has reduced the number of patients to whom it prescribes opioids by more than 22%. Now VA must expand research on the efficacy of non-traditional alternatives to opioids, such as medicinal cannabis and other holistic approaches. The VFW members tell us medicinal cannabis works, and it is a more suitable option than the drug cocktails VA prescribes. VA must research how medicinal cannabis can help veterans cope with PTSD and other conditions such as chronic pain. VFW and Student Veterans of America fellow Christopher Lammy, a Army veteran and LSU law school student, focuses his semester-long research project and advocacy efforts on the VA Medicinal Cannabis Research Act of 2019. Chris's research discovered that veterans experience chronic pain at 40% higher rates than non-veterans, and if not properly treated, such chronic pain often leads to depression, anxiety, and decreased quality of life. Chris also found that veterans who discuss use of medicinal cannabis with their doctors are often have their medications changed or discontinued. The fear of reprisal for medicinal cannabis use prevents veterans from discussing and disclosing information to their VA healthcare providers, which can also lead to drug interaction issues. This legislation will prohibit VA from denying benefits based on participation in the study. To ensure participants of the study do not have their VA healthcare impacted, the VFW recommends prohibiting VA doctors from denying or altering treatment for participants without consultation or concurrence of such veterans. The VFW agrees with the intent of the Veterans Equal Access Act, but cannot offer its support at this time. The VFW agrees that veterans who rely on the VA healthcare system must have access to medicinal cannabis if such therapies are proven to be effective in assisting in treating certain health conditions. Without such evidence, VA would not have the ability to prescribe or provide medicinal cannabis to veterans. It is unacceptable for VA providers to recommend a treatment that is unavailable to veterans at their VA medical facilities, which forces those patients to pay the full cost of such care or rely on other means for those treatments. The VFW strongly supports the provisions of the Veterans Cannabis Use for Safe Healing Act that protect veterans from having their earned benefits eroded or denied simply because they participate in a state-approved marijuana program. Veterans who participate in such programs must not fear that VA will take away benefits they have earned and deserve. However, we cannot support VA providers recommending participation in state-approved marijuana programs if VA is unable to provide such recommended course of treatment. The VFW supports the Veteran Over-Medication and Suicide Prevention Act of 2019 and the Support for Suicide Prevention Coordinators Act. These two bills would make strides to reduce veteran suicide. Veteran suicide is a serious issue. We must do whatever it takes to save the 20 veterans who take their own lives every day. Madam Chairwoman, this concludes my statement. I'm happy to answer any questions you or the members of the committee may have.
Thank you, Mr. Fuentes. And I now recognize Stephanie Mullen, who is the Research Director for the Iraq and Afghanistan Veterans of America. Thank you for being here.
Thank you. Thank you, Chairwoman Brownlee, Ranking Member Dunn, and distinguished members of the subcommittee. On behalf of IAVA and our more than 425,000 members worldwide, I'd like to thank you for the opportunity to testify here today. As Research Director for IAVA, I use the collective experiences and views of IAVA members to support our policy and programmatic work, giving numbers to the narratives of IAVA members every day. This work is personal for me. I come from a military family with a mother that served 20 years for this country while raising a family. Many of the issues IAVA tirelessly advocates for directly impacts the people I love most, and it drives my work to ensure that all veterans are receiving the best care and treatment possible. Support for veteran medicinal cannabis use is an important part of our work, and it's why it's one of IAVA's Big 6 priorities for 2019. For years, IAVA members have been supportive of medical cannabis. In our latest member survey, 83% agree that cannabis should be legal for medical purposes, and a resounding 90% believe cannabis should be researched for medicinal uses. IAVA members are calling for cannabis research, and it is past time for the Department of Veterans Affairs to catch up. This is why IAVA is proud to support the VA Medicinal Cannabis Research Act, which will advance research and understanding around the safety and effectiveness of cannabis to treat the signature injuries of war. However, research takes time, years in fact, and veterans are suffering from their injuries today. With over 30 states legalizing medical cannabis, if veterans are unable to go through VA to get medical cannabis, they'll go around it. But veterans shouldn't feel that they have to hide and circumvent VA to access a standard of care their civilian counterparts can access easily. We know this is already occurring from IAVA members nationwide. In just the last month, over 100 IAVA members have shared stories of their cannabis use, with dozens sharing how VA retaliated against them or mishandled their information, and dozens more sharing that they flat out refused to tell VA about their cannabis use. While current VA policy allows for clinicians to talk to their veteran patients about cannabis, VA clinicians are unable to recommend cannabis to their patients, fill out state cannabis medical forms, or recommend the best programs and options for their patients. These limitations have negative impacts on the overall care of veterans at VA. For these reasons, IAVA is proud to support the Veterans Equal Access Act, the Veterans Cannabis Use for Safe Healing Act, and the Whole Veterans Act. Though cannabis reform is an important pillar in our advocacy efforts, the top priority for IAVA and among our membership is suicide prevention among troops and veterans. In 2016, the latest numbers available, an average of 20 service members and veterans died by suicide each day, accounting for over 7,000 deaths each year. Each one of these deaths impacts an entire community, a family, a friend group, a military unit, and the lives of each and every person that veteran or service member touched. IAVA members know this well. 59% of our membership knows a post-9/11 veteran that's died by suicide. That's a rise of almost 20% since just 2014. IAVA thanks the subcommittee for highlighting this public health crisis, and we're pleased to support the Veteran Over-Medication and Suicide Prevention Act, the Veterans Care Quality Transparency Act, and the Support for Suicide Prevention Coordinators Act. Increasing our understanding of veteran suicide, the risk and protective factors surrounding it, and the effectiveness of suicide prevention programs at VA are all essential to tackling this issue. While we recognize and appreciate the intent regarding veteran suicides on VA property behind the Fight Veterans Suicide Act, IAVA has some concerns regarding this legislation. When a veteran dies by suicide on VA property, to include the tragic veteran suicide just yesterday at the VA in Cleveland, it indicates that the foundation of trust between the public and VA has been catastrophically undercut. These tragic events should be a call to action. To ensure that all VA policies and procedures surrounding VA emergency mental health care, facility security, and personnel training are up to date, acceptable, and being implemented correctly. A failure in the system should and must be addressed. IAVA recommends that the proposed legislation focus on these procedures and policies at VA facilities that may be able to intervene in a moment of crisis, rather than the individual factors surrounding the tragic event itself. Members of the subcommittee, thank you again for the opportunity to share IAVA's views on the issues today. I look forward to answering any questions you may have and working with you in the future.
Thank you, Ms. Mullen, for your testimony, and thank all of the witnesses as well for your testimony today. And so we will now begin the question portion of the hearing, and I will recognize myself for 5 minutes. I think the first issue I really wanted to address is the cannabis issue. We've got a couple of bills before us, which I think are good bills, and the VA doesn't support those bills. We have the VSOs all speaking in favor of these bills. This is, this seems to be an issue that has been going on now for a while, this schism between what the VA believes and what the VSOs want. And this is a big frustration for me because I think it's overwhelmingly clear amongst the American people and amongst our veterans across the country that this is an issue that they are keenly interested in and want to have access to. So I guess my question is, how are we going to reconcile this? You give, particular reasons for why you don't support this legislation. I can't speak whether these issues are valid or not, but if they are, how are you working with the VSOs to kind of work through, these two bills, but there are going to be more. Because of the interest of our veterans and the interest of the American people. So, Dr. Franklin, if you could just respond to that.
Sure, I'd actually ask Dr. Larry Moll, our lead in this area, to respond.
Good morning, and thanks for the opportunity to speak today. I think for VA, and we've seen legislation come in over the last few years, and our kind of rate limiting step is the authority related to being able to recommend or prescribe is related to the Controlled Substance Act. And as long as cannabis or marijuana remains a Scheduled I drug, then we are going to look to the DEA and the Department of Justice to give us their opinion on what our prescribers are able to do. And that's kind of, I think, a short summary of where that process is at. And so I think this committee can make strong proposals to us to move forward with recommendations, filling out forms and such. But at the end, we will need to go back to DEA and Department of Justice for their opinion. And I've not seen anything myself that suggests their opinion will change.
And so what role does the VA play in terms of working with DOJ and DEA? I mean, what kinds of meetings are you having? What kind of conversations are you having to try to push the envelope in support of our veterans?
I would say there are very few meetings that occur, and it's because and I'm not an attorney, so I can't speak from an attorney's opinion, but I think they're waiting to see that something changes from a regulation perspective that then they would respond to. And that's, I think, the best way I can summarize it. I mean, we can go to DEA and Department of Justice, but they're going to continue to point to the Controlled Substance Act until there's a change in that act.
And so you can't even do the research on efficacy because of this?
Research is a whole different question. And we can get to that, but in terms of the recommending, prescribing, that's where the Controlled Substance Acts is the authority of what we do.
Okay, thank you. I'd like to hear from the other witnesses in terms of, your perspective on these issues.
Ma'am, thank you very much for bringing these issues and considering them by the committee. Very important, and have the support of the overwhelming majority of the veterans community. I would have to say that, I agree, the VFW agrees with VA in terms of prescribing something VA can't provide through its pharmacies, but VA should conduct research on medical cannabis. They claim, and previous testimony has also said that they have the authority but still haven't done it. CBD is not medical cannabis, and I encourage VA, the VFW encourages VA to continue CBD research and do more of it, but it's not exactly what we're looking for here with this legislation.
Thank you. Any other comments? Ms.
I
Mullen?
would say as well, research is the key. Everyone wants to make sure that this medicinal cannabis would be beneficial to veterans. We want to make sure that there's no harm done. So the research is the first step to doing that, and that's essential. But I think even more importantly, as Stephanie and we've mentioned, is that veterans are using this as a medication to try to stem their symptoms, whether that be from chronic pain, PTSD symptoms and others. So we know that they're doing that, and we've heard some of the repercussions for that happening, and we want to make sure veterans are safe and have access to all treatments that may be beneficial to them. So this is a critical piece to move forward, and I hope VA will be able to address on the research side. I know they mentioned some of that in their testimony about, how things like that are conducted, so that type of research.
Ms. Mullen.
Yeah, I think that you described the tension between federal and state policy well, and that tends to be the biggest factor when we're talking about VA and recommending cannabis and allowing it in pharmacies. I do think it is within the purview of this committee within Congress to close some of those loopholes and ensure that VA clinicians, while maybe not able to recommend it directly, can at least advise where to go for it, what state medical places they should be looking at, because right now it's going completely under the radar. And again, with the VA policy that's currently in place, right now veterans are supposed to be able to talk to their providers about their cannabis use, and it shouldn't be used against them. I think in practice that doesn't always occur. And so having some sort of legislation that would actually protect veterans would be very helpful.
Dr. Dunn.
Thank you, Madam Chair. I think the H.R. 712 has engendered a lot of interest here. I would like to address it. Mr. Mole, you went right to the heart of the problem. I think that the physicians feel, and that is, so there's a federal law that makes it illegal, and there's multiple state laws that make cannabis legal to prescribe and discuss. And yet the physicians and all the clinicians can be prosecuted under either state or federal law. So we're not, I think, in a position here to actually protect the VA physicians who want to disperse or prescribe cannabis unless we change that law. So we might be looking at the wrong leverage point when we address these laws without addressing the schedule of the drug and the actual punitive actions on it. I could not agree with you more that we ought to be doing research on this. I think we ought to change the schedule to Schedule 2. It seems like every committee I go in, we have another discussion about cannabis. It was in banking not too long ago. Can we bank people who sell cannabis? No, we can't. Yes, we can. No. It depends on if it's federal or state law, right? And so, the poor person who gets involved in actually helping patients with this substance, potentially helping them, can go to jail in any one of a number of venues. So thank you for bringing out that what we need to do is move from Schedule 1 to a Schedule 2. And I get that's the major objection, right, on the VA's part of that. But let's take a look at 712, the research, very quickly here. You have expressed reservations on the design of the study as well as the fact that it's not a Schedule 2 drug. Would you help us redesign this bill in such a way that the protocol would suit the VA? Dr. Franklin?
Absolutely, I'm sure we would. Yes, sir.
Okay, so you could see your way forward doing, cannabis research on tetrahydrocannabinol as well as cannabidiols and all those things, as long as we made it legal for your researchers to do that.
Yeah, I would just add that it is legal for our researchers to research cannabis, cannabidiols, marijuana, whichever label we want to use and whatever product it is. And so they are able to do that. That's a folklore that's kind of been around, unfortunately.
But it's difficult.
Yeah, it's
a very controlled drug.
There's some extra steps you have to do. But as Dr. Franklin said, we have one investigator who's funded by VA right now down in San Diego. So far.
Busy investigator.
Well, I can tell you she has a lot of great ideas. But if you look also at some of the state programs, so Colorado and California, they have supported a number of clinical trials. And in fact, Colorado has a clinical trial looking specifically at PTSD, and they're funding a VA to do that work. So I believe this is beginning to expand in the direction it needs to go, so we get more knowledge, we get some more experience to do the more comprehensive study that you've proposed.
Thank you. Also, Dr. Franklin, you expressed concern about the reporting timelines up now on H.R. 100. Are there timelines that do make sense to you? for the reporting on the, this is the Veteran Over-Medication Suicide Prevention Act, 100?
I don't
HR?
think timeline's the issue. The issue is we spoke about this last night with regard to this proposal. Definitely in spirit and intent, there is a need to do this type of data and surveillance. The issue is when you look at 20 veterans a day that end their life by suicide and 14 not touching the VHA healthcare system, the way the proposal's laid out, it would call for VA to capture medication issue and the like from potential deaths that happen outside of our system, not only from veterans that might be accessing care through our choice program, but veterans access care through other entities as well. So if
You're saying difficult then to get the data? Is that what I understand?
for those veterans that don't receive health care in
Right.
our healthcare system. If it were strictly VHA healthcare system proposal, provide thus and such as written in the proposal, with those that get health care through our organization, it would be a thumbs up.
Okay, good. That's exactly what I wanted to underscore. With the 30 seconds left to us, Ms. Alem, you said that the AV could support certain sections of H.R. 100. It's the same bill, the suicide reporting. What part of it do you oppose? What part do you favor?
I think what Dr. Franklin has mentioned, we were concerned about the types of data collection and then how, it might be misleading in terms of how that's interpreted. But, certainly looking at VA data and what they have available, we want to see oversight, obviously, of black box medications and prescribing practices. So I think just making sure that VA's experts in this have looked at it and feel that it's going to benefit.
Thank you very much. And I want to say, Madam Chair, that it comes up again and again and across all the committees. We need to get this drug into a Schedule II status, and it makes everything so much easier to do. Thank you. I yield back.
Excuse me. Mr. Lamb, 5 minutes.
Thank you, Madam Chairwoman. Dr. Franklin, we talked a little bit about whole health at last night's hearing, and you heard some of my comments about it today. And I appreciate your suggestion on maybe even widening the scope of our bill now or in the future. Could you go into a little bit more detail about that, about the planned expansion from 18 to 36, and then also what you think we could learn from the wider VHA experience, if we looked beyond those 36 sites? And as relevant to suicide prevention, of course, but just really in any manner that's effective
Absolutely.
for
I'm
veterans.
pleased that we have Dr. Gaudet here to talk about it, but I'm
Sure.
also too happy to
Either of you,
engage as well.
fine. Yeah,
Right.
Ask
thank
her
you.
to take the lead.
Yeah, thank you. It's an important question. And the reason we were hoping to actually expand that report is that we do have an intention to do a national deployment of whole health. And I'm sure you're aware, but other members may not be, that whole health includes complementary integrative approaches, but is actually way broader than that. It's really redesigning how healthcare works to start with what matters to the veteran, to help them explore a sense of meaning and purpose in their life. And that's primarily done through trained peers. So while we have the 18 flagship sites that are fully funded to implement the entire whole health system, 140 healthcare systems are doing aspects of whole health. So we would love the opportunity to report back to you on the national deployment and where those strategies are, along with the next 36 sites.
Great, thank you very much. Can you talk a little bit more about, they told me about this when I visited the DC site, but I presume that the expansion that has happened beyond those 18 sites, does it have to do with the trainings that VA has made available for peer and other health coaches to then go back? I mean, that was kind of the way they explained it to me, that there was a
Right.
voluntary program where you could come and learn some of the practices even if your site didn't.
Right, so there are 3 core elements in this redesign of healthcare. Of course, clinical care is critical, and that's in place. The 2 newer elements are the peer piece, which is designed around empowering. And I honestly believe, and as it relates to suicide prevention, that this is the most powerful piece of this entire approach. Trained peers to work with other peers around regaining a sense of meaning and purpose in their life. Then from that point, and there are peers trained at every facility now. So that's offered whether they're a flagship site or what other aspects you're doing. In addition to that, the real goal of the peer piece is empowerment and engagement in your life. But now veterans need support in new ways to approach their life. So the well-being programs, which you described in DC, places where veterans can drop in, have experiences in yoga or mindfulness or nutrition or battlefield acupuncture, a whole myriad of self-care strategies that empowers them is the second element. So different facilities are doing different elements. The 18 are doing all of those three components, and every facility has trained peers.
That's great. Thank you. Has VA already decided what the new sites are going to be from the 18 to 36? Is that
Yeah, we
finished?
have, so each network has proposed 2 sites, and thus 36, and those haven't been announced yet, but we have those 36, and that collaborative will start this summer.
Okay, excellent. Thank you. I'll be hoping beyond hope that one of the Pittsburgh sites might be included, but if not, we will certainly work hard to get our share of the
Absolutely.
program underway. Maybe I could become a peer
That would be
something. You know, I
fabulous.
mean, they tried to put one of the acupuncture
Acupressure,
ear
yeah.
things on me when I was there at DC. It didn't quite work out, I don't think. But
We can arrange for that.
yeah, I applaud your thinking and your expansion efforts on this. You guys are ahead of the game, I think, and I do think it's a big part of the future of healthcare more generally, not just for veterans. And I guess one last thought, if you have anything, Dr. Franklin, on it, is I also see a program like this as a way to appeal to veterans who are not really using the VA system right now, because I think it just matches a little bit more about what younger people in particular think healthcare should be like. Do you think it's a way that we can find to reach these 13 veterans of the 20 every day who are not coming to the VA for services?
Yes, absolutely. I've been in close collaboration with Dr. Gaudet on this very issue, particularly within the first 12 months of time when they leave active duty service. We've had a project together where we're working on trying to help transitioning service members right when they leave the DoD roll right into the whole health program and start their VA experience that way.
Thank you very much for your efforts, Madam Chairwoman. I yield back.
Thank you, Mr. Lamb. And Ms. Rodenwager, you have 5 minutes.
Thank you, Madam Chairwoman. I want to thank the panel for appearing today. My question is for Dr. Franklin.
Yes, ma'am.
In your testimony, you referenced the development of a new Suicide Prevention Coordinator Program Guidebook and a Suicide Prevention Program Directive. When will these be approved and released to the field?
I don't have the exact dates with me, but I can definitely get those back to the committee in very short order.
So in your opinion, is the suicide prevention program and the coordinators who are responsible for its execution, are they consistently trained and monitored throughout the VA system?
Yes, they are consistently trained and monitored, and they're trained through a number of different portals and avenues that I can run through with you if you're interested. And then there are a number of oversight processes and protocols in place at the VISN level and at the VACO level through a number of bodies. I'm happy to get into more details with you. I'm also cognizant of the fact that you might have more questions, so.
Yes.
Okay.
So, Dr. Franklin, I think a study such as the one outlined in H.R. 1647 could be useful in helping to define the prior scope of VA cooperation with nonprofit and community entities in its suicide prevention work. Do you have an estimate as to how many such agreements currently exist, and give us an example of one or two and how they're working?
Sure, absolutely. So within my program in suicide prevention, we have a total right now of 68 partners, and this is just my little program. This does not, little I shouldn't say, this does not count for the choice program and all the partners in other entities across the VA. But we have 68. Of those, 34 are signed MOAs or MOUs, and others are just informal, and they agree to partner with us, and we do good work together, but we've not solidified it on pen and paper. And I will give you an example of one with Walgreens. So we have an MOA with Walgreens reference the 14 veterans, that there may be some veterans that might pick up their prescription at Walgreens, and they might touch a Walgreens facility. So this MOA calls for us to train Walgreens pharmacists on veteran culture, cultural competence, what it means to wear the uniform, and how to ask the question, have you served, and have you worn what is that like, and to really join with our veterans. And then it teaches them also about suicide prevention risks. So I actually train all the pharmacists in Walgreens on suicide prevention myself. I get on a webinar and I train them, and I go through a series of Q&A with them to bring them up to speed on everything from our veteran crisis line, our campaign around Be There, hashtag Be There for Veterans, and around how to ask the question, are you thinking of ending your life? How many prescriptions are you on? And then Walgreens also takes our veteran crisis number and pushes it out to all of their employees at the pharmacy. They give it also to veterans and veterans' family members, and those are just a few examples, but all of that is written into stone on the official MOA, and we stay true to it. It's not a legally binding document, but it does go through legal review, and we track the metrics according to it. So, for example, how many pharmacists have we trained? How much engagement have we had with Walgreens? So that's one. We also have an agreement with a nonprofit called the Independence Fund, which is a VSO that works with us on reunions. And this is a brand new one, so I'll give you sort of the other side of the coin because Walgreens is sort of well established. The Independence Fund, recognizing the role of social support in preventing veteran suicide and peer support, has partnered with the VA to reconstitute military units of veterans, bring them back together for a reunion. And we partner with them. The VA's role in that is to provide the education, the psychoeducational content, classroom instruction, and design the evaluation protocol. They're in the pilot stage, so we've got to grow the evidence on this. It's small pilots. We've had one so far. The second one is coming up the first week of May, where we'll continue to test this model of bringing units back together.
Thank you. Thank you, Dr. Franklin.
Yes, ma'am.
But looking ahead to the implementation of the President's Prevents executive order that would provide for grants to communities to increase collaboration, how do you envision these grantees coordinating with your other partners?
Yes, this is an important thing that we've been talking about in the building as well, so I appreciate the question because there are a number of existing partners that are going to be able to bring capabilities to the table. And so we're planning on hosting a series of webinars and informational instructions to share best practices across the new and innovative community partners that will likely come to the table from Prevents with the existing infrastructure in such a way that we can leverage force multipliers in that equation.
Thank you so much. Madam Chair, I yield back my
Thank you.
time.
Thank you, Ms. Radawag. And now we have Mr. Cisneros for 5 minutes.
Thank you, Madam Chair. Thank you all for being here today. First, I got a question for the VSOs. I'm getting like an echo. I heard repercussions for, that was somebody said that veterans that are going and they're afraid of repercussions when they've talked to the VA doctor about marijuana use, or they've had repercussions for bringing it up to their VA doctors. Can you give me an example of any veteran? What type of repercussions have they had, for bringing that up to their doctor?
Yeah, I'll start. So I won't use names to protect our IAVA members, but we've had several tell us that they will talk to their VA clinician about their cannabis use, and suddenly in their charts it'll say that they have a substance use disorder. And once that happens, it means they have to go through certain procedures to get their benefits back, to get medications back, or in other instances, they'll be taken off certain medications because of their cannabis use, where there's no interaction. For example, perhaps they're on some sort of opioid for chronic pain, and they talk about using cannabis as another factor that helps with that. And there's research to suggest that using both in tandem actually does help that. And then all of a sudden that prescription is taken away from them. So that's just two examples.
And Dr.
Sure. I also offer that I'm happy to take it back to the organization to double down on our efforts to educate providers and nurses and physicians on this issue to make sure that there are no repercussions. And if there are individual case studies, I know Dr. Moll and I are happy to chase those down and ensure that there are no ramifications or negative consequences for veterans.
Well, that was my question, to you, is you said that patients are allowed to discuss this with their doctors. But is there a VA policy in place? Is there a directive in place that says they're allowed to bring this and there won't be any repercussions, or that they won't be, listed as a substance abuse? I mean, what are those policies?
So the policy isn't as prescriptive as you won't do A, B, C, D, E. But it says that you will not be denied benefits. We encourage you to have a conversation. We encourage the providers to document that so that other providers know and are aware. and to use that information as part of the treatment plan and how you develop what's appropriate for that individual veteran. That's what we ask for the providers to do. And I second what you're saying is we want to take a look at providers who are deviating from that policy. Absolutely.
Double down on this.
Yeah, no, I would appreciate that, and, Representative Staub, here's his bill right now that I'm happy to co-sponsor with him. I think is doing a great deal that'll go and make sure that these veterans don't have to face repercussions and that they can feel comfortable talking about their plans with their doctors, and I'm glad that he brought forth that legislation. I'm glad he came to me and asked me to be a co-sponsor of that. Just another question going in a different direction as far as the study that you said the VA wasn't supportive of H.R. 712. Now, you had mentioned that one of the reasons was that there should be a smaller study first, but, this is a crisis situation. A lot of these veterans are using this because of chronic pain to deal with PTSD. Why not do the big study first, to go out there and to do this, to kind of find the problem and do the research that needs to be done so that hopefully we can get to that point where hopefully the VA one day can start prescribing cannabis to help treat these conditions that our veterans are dealing with.
Yeah, there are a number of study protocols when you're designing a research study, and just a number of processes and reviews when you're looking for evidence, and typically you've got to be safe and do no harm and start small and grow evidence over time. But certainly we can work with the best academics in this space and make sure that we're designing it at the right size that both gets after the evidence that you're after and protects human subjects at the same time, without a doubt.
Yeah, no, I like I said, I think we're in a situation right now where we can't be taking baby steps. We got to start running and to get there, and if it takes a bigger study to help us do that, then that's what we need to do. And so I'm also very supportive of H.R. 712. But I yield back my time. I just want to thank you very much for being here today. Thank you.
Thank you, Mr. Cisneros. And next is Mr. Stubbe.
Thank you, Madam Chair. First, I just wanted to thank you for bringing up H.R. 2191, Veterans Cannabis Use for Safe Healing Act. I represent Florida, and Florida recently has gone through a medicinal marijuana ballot initiative. I was actually involved in the state legislature where there was legislation and then became a ballot initiative. And I'll say, Dr. Franklin, you had stated that the VA is not denying benefits to veterans. That's not what I'm hearing from people in Florida. Just Google my district, and I just went on a local newspaper, and there's like 10 different articles, interviews on local stations. So at the very least, I think there's an incredible amount of confusion as to whether veterans who have gotten the way it works in Florida is you have to get a prescription by 2 independent physicians to then get medicinal cannabis. And I think there's definitely some confusion, and I have heard from veterans directly who have said they have been denied benefits from the VA because they've tested positive for marijuana and THC. So I think that's why I did the bill, because at least in Florida, I've seen some real challenges in Florida as the application of state medicinal cannabis bills and veterans who are using VA benefits. So I think it's important that the law is clear. You said that there is a directive, the Administrative Directive 1315, but isn't it true if a new administration came along or a new secretary came along, can't a directive change or be canceled out?
Typically, at the bottom of the directive, they'll have a statement that says something like, and this is generally, I haven't looked at this exact one, but it will say this remains in effect until, and it will have a date and time, or it will say upon the change of leadership, this must be updated. Or so without seeing it, although it looks like maybe Dr. Moe might have a copy of it, but I hear your underlying message, which is confusion and need to do proper education and outreach to veterans and communities across the nation on what the parameters are and making sure folks know about this policy and that it's not taken in a negative way for veterans.
Well, but you guys are stating that you're against the bill that we're working on that would codify this, and that's my question, is saying can't directives change? I mean, if a new secretary comes in and changes this specific directive that allows veterans to utilize medicinal cannabis, if we have a law in place that says legally under the 10th Amendment to the Constitution and the federal government has recognized that if states have legalized medicinal cannabis, that the VA shall not deny veterans benefits, I think that would go a long way to assuring that there isn't confusion within states that have authorized medicinal cannabis. So I understand from the DEA perspective why you're against part of the bill, but you have a directive that basically states what we're trying to make law, and so that it's not confusing to people in states that have legalized it. So, I mean, I'd be happy to work with the VA on this issue. I'm very passionate about this issue because it's a big issue for Floridians. I didn't even vote for the ballot initiative that passed, but it has passed, and I believe under the 10th Amendment of the Constitution, that's the law in Florida, and veterans should not be denied benefits that they are due and owed for their service to our country just because they now have a prescription for medicinal cannabis. I think it needs to be very, very clear that that's not going to happen to them.
Yeah, and I think we'll take this back, and we're happy to work with you and others on that language.
And if there's other, you had mentioned several things on that specific bill that I'm working on that you have issues with, but I'm happy to work with you moving forward. I think it's certainly an important issue to a state like Florida that has, and it's new in Florida, this has only been around a couple of years, so they're going kind of through their legal growing pains as well. But I think it's important that our veteran community and states that have authorized it, those veterans know that they're not going to, and if you Google what I told you to Google and you watch some of the interviews, veterans are actually afraid to go to the VA to use services that they are accredited to do, because if they test positive for THC or marijuana, they're afraid that they're going to lose their benefits. So it's certainly, there definitely needs to be some messaging to veterans in states like Florida that you're not going to lose your benefits if you legally are using a state, sanctioned medicinal cannabis act. So thank you, and I'm happy to work with you on that.
Appreciate it.
I'll yield back the balance of my time.
Thank you, Mr. Stubbe. Mr. Rose, 5 minutes.
Thank you, Madam Chairwoman. I just want to address something quickly with the VA to clear up some confusion. We've heard concerns regarding potential HIPAA violations in regards to the bill I, along with several others on this committee, are introducing Fight Veterans Suicide Act, requiring the VA to notify Congress of certain information regarding veterans that die by suicide on VA campuses. Particularly, it asks for the enrollment status of the veteran with respect to the patient enrollment system of the department, the most recent encounter between the veteran and an employer or facility of the Veterans Health Administration, whether the veteran had private medical insurance, the armed force and time period in which the veteran served, the age, employment, marital status, housing status of the veteran, and confirmation that the Secretary of Veterans Affairs has provided notice to the immediate family members. To your knowledge, does the requested notification require the release of any protected health information and is thus subject to HIPAA protection?
I would need to put that through a full HIPAA review with our attorneys. I don't have the law memorized, and I'm not sure, but I will tell you that one of the things that that is concerning that we're trying to balance, although you heard in my testimony that we absolutely approve, we recommend, and we give this a thumbs up in terms of full support for this report to Congress, is just making sure that we're careful around notifying people in general about suicides that occur in districts perhaps where there's just a very small number, and if that got released out to the media in a way that were reported and a mother or grandmother or wife of a veteran that ended his or her life by suicide saw that swirl out in the media in a negative way that impacted their family. So it's just a matter of preserving the dignity there. But in terms of HIPAA, we can run it through the HIPAA legal review and tell you what the outcome is.
But you're not seeing any glaring red flags right now, or else, I mean, the VA just endorsed the bill. I don't think you would.
So likely the attorneys looked at the
Sure.
review. Looking at it from a social science perspective, I don't.
Okay.
But-
All right. No, that's very helpful. Ayava, I just wanted to really ask you all a quick question. Speaking to the VA folks last night, raised certain facts and figures that show that multiple deployments that are packed together with minimum dwell time, as well as minimum training time prior to an initial deployment, then a second deployment, do substantially increase the risk of suicide. Have you seen these stats bear out amongst your membership?
The short answer is absolutely. You can see from our members that 75% have served in Iraq, 39% have served in Afghanistan, quick math shows you that's more than 100%. And we know, we asked about deployments as well, and most do at least one OIF and at least one OEF.
Sure.
We deal with a population that has multiple deployments, most of which are while they're doing guard or reserve duty, which was another topic of conversation and something that IAVA is concerned about, especially when we're talking about the suicide rates when it comes to guard.
Absolutely. No, look, as a guardsman presently, as a vet who has too many friends who deployed 5, 6, 7 times, I think it's our responsibility as well to make recommendations to the DOD as to what is responsible and what is not. And so we're here today considering veteran suicide. We're here today considering overall veterans' health. All present service members are future veterans. So what, if any, specifically, recommendations would you make to the DOD as you are concerned about Iraq and Afghanistan veterans as to dwell time, as to op tempo, as to minimum training prior to deployment?
It's a great question. When it comes to specific timelines, IAVA does not have specific recommendations to that, but we do hold very high the health and well-being of service members and their families. Coming into that is not only the health of the service member, but the experiences transitioning back from deployments. Moves within military families, how many moves they're doing, the impact on their children and wives, spouses, husbands, whatever it may be. So of utmost concern, but I don't have specific recommendations.
And do you think, in your estimation, the VA should be in the business of making recommendations to the DOD about op tempo and dwell time?
I would say I don't have the background to make that recommendation. I know that VA is doing a lot to support transitioning service members, especially in their last 18 months and as they transition out. I think that's a key time frame where VA should be engaging with service members as they're going through the TAP program and ensuring that they're making a smooth transition, especially because we know that is a heightened time for suicidality among that age group and among that transitioning service.
Yeah, and look, I'm just going to close out with this, though. The message I got from the VA yesterday, and we all did, was that there are certain things out of their control. There are certain things out of their control, one of which is op tempo, one of which is the intensity of modern-day combat. And what I still do not yet understand is if there are certain things out of the VA's control, why would the VA then not make recommendations to the entity unto which that is under their purview?
Look, I will share with you that I worked for the DOD and I've only come over to the VA in the last year, and we can and will make recommendations to everybody and anybody in this enterprise when it comes to saving lives. And so whether or not DOD will embrace those recommendations is likely to be determined. But when you're talking about dwell time, there's not only the issue of multiple deployments, but it's also the issue of length of deployment. And so
Totally agree.
there are some studies that show that troops can deploy out 3 months 7 or 8 times and be fine. And then there are other studies that show they'll deploy out 1 time for 18 months, and that particular type of combat and or deployment will crush them for months to come. And particularly when it applies to coming in and out of roles with regard to being a spouse and a parent. And so all of that is quite complicated. And to the extent that that's been studied or can be looked at longitudinally, and we can give those recommendations to the DOD, I'm sorry, we can and will.
So I, you know, as I think of my friends who have done 15-month deployments, and I never did, but that's 2 Christmases, 2 birthdays,
sir.
2
Yes, sir.
anniversaries.
I-
You know, you deploy when your kid is 6 months old. For 15 months, you come back and your child doesn't recognize you, doesn't
Yes.
know who you are. So what I'm hearing is that you are now, the VA is comfortable making recommendations to the DOD as to what is acceptable or non-risky op tempo, and what are the types of op tempos and the lengths of deployments that do present potentially undue risk for future suicide.
We will tell them what we're learning about suicide up, down, and all around. What we won't do is get into the business of war fighting with them. And this
Of course, and no one.
Very well.
I mean, I understand that.
Yes.
I wouldn't want you in that business.
Yes.
But I do want you.
Mr. Rose, your line of questioning is very good, but your time is,
Understood. Thank you.
yes.
Thank you.
Thank you, Madam Chairwoman, and I agree. Great line of questioning there. So I was enjoying listening to the dialogue. Let me shift gears, Dr. Franklin and Dr. Gaudet. Earlier this year, Dr. Stone with the VHA stated that the VA had 60 active equine programs across the VA system and concurred that they are very effective in benefiting veterans. Last night, we heard from the National Institute of Mental Health, similarly, that equine-assisted therapy programs have some benefits in terms of mindfulness and other benefits, especially for returning veterans who are struggling with post-traumatic stress and other issues. I was very encouraged by Dr. Stone's statement that the VA is actively looking to expand equine-assisted therapy, as well as all of the VA's adaptive sports programs. Is equine-assisted therapy included in the services offered through the VA's Whole Health Initiative?
I can probably take that. Thank
Great.
you. The concept of the Whole Health Initiative is a broad umbrella. So while technically that doesn't fall under my office, really doesn't matter for this conversation. What matters is that the concept of supporting people's health and well-being and resilience through any means that is of effect and benefit for that veteran is a part of that approach.
Well, this is Kentucky Derby week, and horses are on my mind as a
Yes, of
Kentuckian.
course.
But I can tell you on a more serious note that throughout the calendar year, I have witnessed some really transformational things, positive things happen with veteran constituents of mine who have the benefit of access to equine-assisted therapy that may not exist in places outside of Kentucky, for example, and I encourage you to look at that. In legislation offered by my colleague, Mr. Land, there is a provision that allows the VA to report on the accessibility and availability of any other service the Secretary determines appropriate. If passed, Dr. Franklin, would you be willing to include equine-assisted therapy as part of this report?
Yes, sir.
Thank you. Let me shift gears to some of the cannabis-related legislation on the docket here today. Back to you, Dr. Franklin and Dr. Gaudet. As you may know, the 2008 Farm Bill took steps to deschedule industrial hemp-derived CBD products. And a lot of people don't fully appreciate the distinction that was made in the Farm Bill related to low THC CBD cannabis versus the high THC marijuana that remains prohibited under federal law. Given the passage of this legislation, has the VA given some concerns about the existing marijuana legislation on the docket today, has the VA changed their approach into researching CBD, low THC CBD treatments for veterans?
I will defer to Dr. Moll.
I'm not sure if that bill would have shifted people, but I think clearly investigators are interested in CBD oils. They're interested in low THC or no THC if that's possible. So I know that work is ongoing, and there's investigators interested in working on those types of products. The Farm Bill, I was having to run through some papers because we had some struggles with how to interpret the Farm Bill versus a Schedule I substance, and so.
Well, if I could,
Yeah.
To the extent the VA has concerns about the psychoactive impact and some of the studies relating to schizophrenia with marijuana, let me assure you that hemp with the low THC doesn't present those potential risks, whereas CBD, which is now legal under federal law, may present an opportunity for the VA to take those incremental steps that you all were talking about in your testimony before. And the Farm Bill, just for informational purposes, does authorize the FDA and USDA to complete regulations. Those are ongoing. And once that is completed, I would encourage the VA to look at CBD as an initial step on this road to cannabis as a potential medicinal opportunity.
So just very quickly, I don't want to use your time. So what Dr. Franklin said earlier in the testimony was that our current study underway in San Diego is using CBD.
Okay, great. Thank you very much. And finally, just to the VSOs, Ms. Mullins, Mr. Fuentes, and Ms. Ilem, have you all had an opportunity to play a role in suicide prevention to the extent that I know your organizations can? We know from the testimony last night that far too many veterans who are committing suicide are not accessing, at least recently, the VHA system. Do you feel like you all are able to reach those veterans?
I would say for DAV, we just recently had VA come over and do a SAVE program with us, training, making sure that our headquarters staff understands how everybody can participate in suicide prevention. And then we also included that now in our training for our national service officers who are located throughout the country and see veterans every day, assisting them with their claims. So we know and subscribe to VA's premise that suicide is everyone's business. We all have to play our part. We have to include this information in our magazines, our brochures. We have to talk to veterans, make sure that we're all taking care to watch out for each other. So I think, we're doing what we can as an organization to spread that.
It's same thing for the VFW. We have one of those unofficial MOUs with VA, part of our mental wellness campaign, to essentially help veterans and their caregivers and family members in the community identify the 5 signs of emotional distress. Is a partnership with Give an Hour, Elizabeth Doe Foundation, and Walgreens as well, to bring people into our 6,500 posts around the world and train them, part of the Day to Change Direction. So we're doing it, we're gonna continue doing it, and VA is being a good partner.
Yeah, from IAVA's perspective, we operate a bit differently than the legacy VSOs over here, and we build online communities to engage our members in suicide prevention and mental health care, and we do that effectively and efficiently. I will also say that our rapid response referral program has an MOU with the VA as well, that they are master's level social workers that work one-on-one with veterans to do warm handoffs. So when a veteran calls our rapid response referral program in crisis, they're able to connect them to the VCL immediately. Last year, we had over 100 saves through that program. So it's an amazing program. We also have about 25% of our members that don't access VA healthcare. They do private health insurance only. So I can tell you that VA members, IAVA members, are definitely outside the VA program, and we are connecting with them with suicide prevention and mental health care.
Thank you. I yield back.
Thank you, Mr. Barr. And last but not least, Mr. Brindisi.
Thank you, Madam Chair. Sorry for being late, juggling a couple different committees today, but thank you for allowing me to be here, give me an opportunity to ask a few questions about our bill, H.R. 233, the Support for Suicide Prevention Coordinators Act. And I just want to ask just a couple brief questions because I think that coordinators are really the face of the VA's efforts to address the veteran suicide epidemic. And many report being overworked or unable to keep up with some of their responsibilities. So essentially what this act would do is give our prevention coordinators the resources they need to be able to do an effective job, and specifically the bill would require the Comptroller General to conduct an assessment of the responsibilities, workload, and vacancy rates of the Department of Veterans Affairs suicide prevention coordinators and submit it to Congress within 1 year. So I know that the VA hasn't taken an official position on the bill, but I assume that you would welcome an outside assessment by the Comptroller General to conduct an assessment and report back to Congress.
Yes, and I also shared with the committee earlier that we have an assessment well underway where we're looking not only at just the role of the suicide prevention coordinators, but more broadly in the role of other capabilities that we might need to bring to the table as part of our new strategy. We're trying to work with veterans and get after suicide where they work, live, and thrive, which is outside of our 4 walls. The role of the SPCs has largely been focused on clinical work with very limited outreach events, 5 a month. And so we're not only looking at their role, but we have a study underway and an analysis where we're looking at other capabilities as well that might need to get brought to the table.
Can you talk a little bit about, because I represent a very rural district, some of the outreach efforts that are being done in more rural areas where you may not be close to a CBOC or a hospital where public transportation options are pretty poor? How do you conduct outreach in those areas?
Yeah, it's a difficult issue, just as you describe, and we try to tackle it through a multi-pronged approach, whether that's our SPCs, which that alone will not solve it because, as you describe, it's rural and they have to go long and far to get across the span. Using online technology helps, but again, alone will not solve it because not all of these areas have broadband and the width to do it. And then we have our mobile vet centers that will go out. I don't know if you've ever interacted with this capability, but it's actually like a vet center on wheels, if you will, and they'll go out to rural areas. We're trying to target when and where to place them, and we have a movement underway that that allows for that to happen. So that's the third. And then the fourth is we're using partners. And so while we may not be able to outreach and get after this issue with every single person ourselves, we're trying to have our partners help serve as force multipliers and help us with this outreach as well. So when there are local entities and community-based folks that people that live in rural America know well and trust well, and they're equipped with the signs and symptoms of risk, and they can carry VA's message and help us in a coordinated fashion, I think that adds to it. But it's a difficult phenomenon that we have to continue to work on in rural America.
Okay. Well, I'm always willing to work with you guys on that, representing a very large rural district. And we know that access to health care is very hard to come by, especially for our veterans in those communities. So any initiatives that you'd like to partner on, I'm always willing to work on that. Just one last question. I know in your testimony it says that the VA's mental health hiring initiative is active and is addressing current hiring plans. What is the timeline? I know that also you had said that the Suicide Prevention Coordinator Program Guidebook and Suicide Prevention Program Directive are currently in development. What is the timeline on those initiatives?
Yes, for the mental health hiring initiative, we had a goal of June 2019 to hire over 1,000 mental health providers, and we've exceeded that goal. I believe it's at 1,065. We do still have some shortcomings in the area of suicide prevention. We did coordinators. I'm sorry.
Yep.
We did an analysis of that job bucket, and we determined that we needed an additional 386, of which we've hired a good number. We have 244 remaining of that analysis in order to get even with that, with the board, with that community. So June 19, to answer your specific question on the date. I do not have the timeline for the directive and the suicide prevention guidebook, which will really be the force function for working with the suicide prevention coordinators on how to do their day-to-day jobs and an increased layer of accountability, if you will, from the VACO office and the local SPC. But I committed to one of the Congresswomen earlier this morning that I would bring those dates, and as soon as I get back to the office, I'll pull it. I just hesitate to give one that might be off.
Absolutely. If you could share that with us down the road, we
Will
would
do.
certainly appreciate that.
Yes.
I would yield back my time.
Thank you very much, and I think that ends our hearing, but before closing, I wanted to make a couple of points, and really just two. And one is around the topic of suicide prevention, and we have several bills here today that address suicide prevention, and I just encourage the VA, the VSOs, the author of the bills, to try to work together to make these bills work, because I think their intention, and I think most everybody agrees that their intention is good, and making sure that we can succeed in that. And I think, obviously, with suicide prevention, we still have a lot more to do. And last night's hearing was good. This one has been good, and I'm sure we will have more hearings on it. And the second piece is around the cannabis piece too, and trying to make that work. And I will say, I have heard from my constituents and my veterans as well this issue of fear of testing positively and being worried that their benefits will be taken away from them. And I remember a couple of years ago, we had a family come in to testify whose son had committed suicide. He committed suicide, and he left a suicide note, and he basically said he was trapped in his body, that he had been so medicated and trapped in his body that just life wasn't worth living anymore. And so I do think this cannabis issue and proceeding with it and this relationship to suicide prevention, there's a nexus here. And I think we just have to really be committed to the cannabis issue and to the suicide issue, but where this nexus is. And so those are the 2 points and my 2 takeaways from the committee. And again, I just wanted to reiterate this committee hearing. Their members and witnesses went over a little bit in their time, which I allowed. I want to keep the conversation as free-flowing as I possibly can. Other hearings, I might have to call it. This one, we seem to have the time to be able to do it. So I think it was a good hearing, and again, I thank the witnesses for being here. And Mr. Barr, if you have any closing comments, the time is yours.
Just again, thank you to our witnesses. Thank you for your service, for addressing these very important issues. We've got to get this veteran suicide issue under control. 20 a day is unconscionable, it's intolerable, and I appreciate everyone here, both on this side of the dais and also at the table, for working with us to tackle this very important problem. And Madam Chairwoman, thank you for your commitment to that issue as well. Yield back.
Thank you, Mr. Barr. And with that, all members will have 5 legislative days to revise and extend their remarks and include extraneous materials. And without objection, the subcommittee stands adjourned. Thank you. Thank you.